Hi everyone, welcome back to BunMed, where we discuss concise medical knowledge that you can fit inside a bun. Today we'll be talking about blood groups and acute hemolytic transfusion reactions, where I'll detail blood groups and the pathogenesis and clinical features of these reactions. So blood groups. Blood group antigens exist on the surface of red blood cells. These are surface markers which allow the immune system to identify your own cells. Approximately 400 types have been identified, but the most important ones are the ABO and the RH groups. Some others which can be clinically relevant include Kell, Duffy, and Kidd. Starting off with the ABO grouping, an interesting fact to note is that if a person doesn't have a type of ABO antigen already present on the red blood cell, then even if that person hasn't had a pregnancy or a previous transfusion, their plasma will contain antibodies against the missing antigen. So in this case, we have a missing B antigen, therefore the antibody present in the plasma will be the anti-B antibodies. Here we have a summary of the ABO blood group. The genes coding for the A and B antigens are codominant, but the O gene is silent. It's only expressed when neither A nor B is present. This is why a genotype of AO or BO still express themselves as A or B blood groups respectively. Also, the concept I mentioned before can be observed where the A group has the A antigen and as a result anti-B antibodies. This means if A group patients receive B group blood, a reaction will occur between the incoming B antigens and the already present anti-B antibodies. This will result in the acute hemolytic transfusion reaction, something I'll detail in a short while. Something more to note is AB phenotypes are universal receivers as they have no inherent anti-ABO antibodies in their plasma, whereas O phenotypes are universal donors as the O antigen doesn't react with anti-A or anti-B. The most important of other blood groups is RH. Unlike anti-ABO antibodies, these antibodies of other blood groups are only formed by prior introduction. The diagram below shows how this becomes clinically relevant. You have the introduction of blood to the person receiving who doesn't have said antigen. This person will therefore produce antibodies against said antigen and will result in antigen-antibody complex formation. This, by various means, leads to hemolysis. Newborn babies can have a reaction like this if their mothers have a different ABO or RH blood group. With RH groups, this could happen if the mother is RH negative and the baby is RH positive. This means the mother who lacks the RH antigen will produce the antibodies, anti-D antibodies, against the baby. So now we'll move on to acute hemolytic transfusion reactions, a medical emergency. They occur when there's an ABO mismatch and are very violent as the formation of antigen-antibody complexes result in the activation of the complement system and as a result causes massive intravascular hemolysis. To summarize the effects of the complement cascade, you get increased phagocytosis due to the opsonization, you get increased inflammation, thus attracting macrophages and neutrophils, you get cell lysis due to the action of membrane attack complexes. The hemolysis results in hemoprotein release. Normally speaking, hemoprotein scavengers such as haptoglobin and hemopexin will act to limit the circulating levels of free hemoglobin, potentially toxic species that are released from injured red blood cells. The spleen, which is in charge of dealing with old or damaged red blood cells, is currently overworked by phagocytosis. This results in a buildup of hemoglobin haptoglobin complexes, which can then, through a combination of oxidative stress, cytotoxicity pathways, formation of intratubular casts, pro-inflammatory effects, leads to AKI, or acute kidney injury. Important risk factors to confirm in history include pregnancy, previous transfusion, previous transplantations, immunocompromised status, for example, in patients with graft versus host disease, prior history of a transfusion reaction. Going on to the clinical features, The first phase is the hemolytic shock phase, which often features with fevers, rigors, chills, precordial pain, lumbar and loin pain, nausea and vomiting, urticaria, shortness of breath, headache, hemoglobinuria, and hypotension. This can then move on to an oliguric or diuretic phase, a feature which also includes disseminated intravascular coagulation, which is detailed in another video. But the key feature is the progression into acute kidney injury, as mentioned before. This occurs due to renal tubular necrosis or the cell death of the kidney cells. The symptoms and signs include reduced urine output, less than 0.5 ml per kg per hour for more than 6 hours, low blood pressure, high heart rate, and with investigations you'd see increased creatinine and decreased eGFR. So what next? You should immediately stop transfusion and disconnect the patient. You should perform a clerical check, as if a patient component mismatch is present, another patient is also at risk of receiving the wrong blood. You should send the blood bank and tubing to the blood bank with the tests to be done on the samples. Tests include repeat ABO testing, direct antiglobulin test, also known as the DAT or Coombs test. This checks whether hemolysis has occurred, should visually inspect the plasma, check serum haptoglobin and serum creatinine. All of these check for hemoglobin production, hemoglobin in the blood, and the serum creatinine checks if you're progressing into renal impairment. You should also obtain urine samples, which also check for hemoglobin. As for the management of these patients, start off with ABCDE. Check their airways, their breathing, circulation, disability or diabetes, and anything extra. Start off with fluid resuscitation, a 500 ml bolus of sodium chloride stat. Continue until the urine output is stabilized. Monitor the condition, and if it further worsens, consider airway support with intubation and mechanical ventilation, hemodynamic invasive monitoring, dialysis or renal replacement therapy. In summary, blood groups are the surface antigens found on red blood cells. Transfusion-associated antigen-antibody reactions result in hemolysis. Quick recognition and management of an acute hemolytic reaction is vital to the patient. Thank you very much. I hope that was useful. Please feel free to like, share, and subscribe.